Welcome to the Lymphoma Research Foundation's update on COVID-19 vaccination and the Centers for Disease Control and Prevention Guidelines for Lymphoma and CLL Patients webinar. I am Susan, and I'll be your moderator for today's call. During today's call, you will hear from an expert speaker and listen to the questions and answers session where questions have been submitted in advance. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow the link to complete the evaluation for this program and gain certification of attendance. If you are listening by phone, this link will be sent to you by email at the end of the webinar. And now I'm pleased to introduce Victor Gonzalez. Victor Gonzalez is the Director of Support Services and Alliances at the Lymphoma Research Foundation. Welcome, Victor.
Thank you, and thank you to each of you for taking the time to join us on today's update on COVID-19 vaccination and the CDC's guidelines for lymphoma and CLL patients webinar. Before I turn the program over to our speaker, I want to briefly share information with you about the Lymphoma Research Foundation. Access to expert disease information is so important, and we're thrilled to be able to bring this educational program to you. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through education and support services. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. In addition, we have launched our COVID-19 Learning Center on our website at lymphoma.org to support lymphoma patients and caregivers with information about COVID-19 and COVID-19 vaccines. Please visit our Learning Center for access to COVID-19 fact sheets, archived webinars, frequently asked questions, information on financial assistance, and the latest news related to the pandemic. If you have questions regarding what you have heard about today, or if you need information about relevant treatment options and supportive care resources, you can reach out to us by calling our helpline at 1-800-500-9976. A trained staff member will be happy to assist you. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. John Leonard to discuss lymphoma and COVID-19 vaccine updates. Dr. Leonard is the Richard T. Silber Distinguished Professor of Hematology and Medical Oncology and Senior Associate Dean for Innovation and Initiatives at Weill Cornell Medicine. Dr. Leonard is also a member and past chair of LRF Scientific Advisory Board. Thank you for speaking at our program today. Dr. Leonard, I will now turn the talk over to you.
Well, thank you, Victor, and I want to thank the LRF for supporting and initiating this program. I join the many people in the audience for thanking the organization for their efforts to really make this complicated area more clear for patients as it continues to evolve, and of course all that the Lymphoma Research Foundation does for patients. And I would encourage those of you who are not as familiar with LRF to go to lymphoma.org and learn more about the foundation. It really does great work. I support LRF and have done so for decades, and really encourage all lymphoma patients and their families to get connected and to support the foundation. So our focus today is, as you know, on the rapidly changing landscape of COVID-19 vaccination, and the CDC guidelines. And it's exciting. I'm sure those of you who have seen in the news today that one of the vaccines we're going to talk about is now, it appears, fully FDA approved. And so that hopefully will also change the landscape for many people who were looking toward that milestone to get vaccinated. As you all know, many in the country are hesitant for a variety of reasons, and hopefully the FDA approval will encourage more people to become vaccinated And obviously, that's an important part. Our community rates of vaccination is an essential part for lymphoma patients in being protected, because we think of this as kind of like the lottery and the ping pong balls in the plexiglass container of the lottery drawing. The more ping pong balls that you come in contact with, and those that are concerning, the better off or worse off you are. And so having more of those ping pong balls vaccinated protects all of us. So I want to first start by just reminding you about the vaccines that we have available in the U.S. And this is really important because, and it's worth a minute or two of our time, because obviously you have to understand how vaccines work to understand how we can make them work better, and how they protect patients, and how certain patients may not be as protected as we would like. So I'm going to spend just a minute or two on the background before we get into some of the specifics. So, and many of you may know this already, but I think it doesn't hurt to repeat it. The Pfizer BioNTech vaccine and the Moderna vaccine are what we call messenger RNA vaccines. They are derived from or really reliant upon messenger RNA. And so basically what you see under the syringe, kind of in the center of this slide, is that you have a lipid nanoparticle with mRNA that encodes the spike protein from the coronavirus, the COVID virus, which is depicted on the left. And so when that mRNA enters a cell after vaccination, that cell translates the mRNA. mRNA is a very transient molecule, and it gets translated by the cell into the spike protein, and that spike protein then is used to engender and is generated by the cell to induce an immune response. And that immune response can be a cellular immune response. We'll come back to that in a second, depicted a bit on the far right part of this slide, and can also be an antibody response. Antibodies are immune proteins that are these little kind of Y-shaped structures. And the idea being that when those cellular immune response and the antibody immune response are generated, then those immune responses will then go after, as you see in the bottom center of the slide, go after the virus if the patient or the person is infected, and protect that, because the defenses are already there and ready to go. And so the idea is that these antibodies and this immune response can help prevent infection or keep you from getting too sick from the infection. Okay? Important to understand that this is all what happens after vaccination within the person's body, and is relying on the person's immune system to mount and make this immune response. So these mRNA vaccines, the Pfizer and Moderna vaccines, I'm sure many of you have received these vaccines. They're given in 2 doses typically as the initial course, either 21 or 28 days apart. You see that the approvals are a little bit different. The Pfizer is approved for those 12 years and above, and so that's a big issue in our country and in the world, is the fact that children do not yet have full access to these vaccines. And obviously there's a lot of concern out there about schools and people with children having their children bring home infection to them from schools, and most importantly, obviously, for the children themselves, those cases where children can become ill, which seems to be less frequent than in adults, but obviously not zero, and therefore important. You can see that both of these vaccines have been tested in tens of thousands of people and have roughly 95% protection in these studies against COVID infection with symptoms. So these are highly effective vaccines, very important vaccines, and really the best way that one can protect themselves against COVID, and is really important in our lines of defense. There is another type of vaccine some of you may be familiar with or have heard about or have even received. The Johnson & Johnson vaccine is what we call not an mRNA-based vaccine, but it's a viral vector vaccine. And so the DNA to encode the spike protein is in a virus, an inactivated virus, that enters the cell. That DNA is released in the cell. The nucleus of the cell then makes RNA and then makes protein, and essentially part of the same process occurs where that spike protein then is expressed by the cell, and the immune system reacts both to make a cellular immune response and the antibody immune response. So this is another form of vaccine that some of you may have received or may be receiving. One of the potential advantages of this has been that it's a one-dose vaccine as described. It's been given to over 40,000 patients. And you can see that it's also highly effective against severe COVID-19 disease in the U.S. The rates of infection were a little bit higher in other parts of the world, partly because of, or what seemed to be partly because of different strains in different parts of the world, led in some of the clinical trials for the infections protection to seemingly be a little bit lower. So this is a one-dose vaccine, a little bit different in how it works and the data on it, but nonetheless also very effective against protecting individuals against COVID-related infections and particularly disease and severe disease from those infections. So those are the three available vaccines in the United States, and it's very, very clear now, and I think really no debate, that these are safe vaccines and they are highly effective vaccines, and they are recommended for those in the groups eligible to receive them. And these are largely either adults or, in the case of the Pfizer, as I said earlier, 12 and up. And so children, the main group that is excluded from vaccination or is not eligible for vaccination relates to those younger individuals based on the parameters that I just mentioned. So now we're going to turn to patients with what we would term compromised immune systems, and that's the focus of the rest of our discussion today, is the fact that some people, for a variety of different reasons, have immune systems that I like to call imperfect. They may not function as what we would call a quote-unquote, if there is a normal person, someone who has what we would assume to be a relatively normal immune response. There are some patients that have compromised immune systems. So why might those patients or those individuals benefit less from a vaccine or have the vaccine not work as well? Well, the antibody immune response that we just went through, you need B cells. B cells are immune cells that essentially interact with those proteins in a vaccine or in an infection, and those B cells, in response to infections, proliferate and grow and mature and make antibodies, develop into cells that make antibodies. So if you don't have B cells, or if your B cells are affected in some way or damaged in some way, you may be less likely, for a variety of different reasons, to make those antibody immune responses. On the other hand, another part of the immune response to a vaccine is what we call cellular. Cells of the immune system, particularly T cells, but there are others, these contribute to different infections and the immune system's reaction to different infections. These are much harder to measure. They're much harder to gauge and to say, is this working or not working? Which cells are key? What do they do? But the cellular immune responses in people with certain compromised immune systems that affect the T cells and these other immune cells may also be impaired or not work perfectly to varying degrees, and therefore, to the extent that that contributes to the protection from a vaccine, that may be a factor in the effectiveness of the vaccine, because the vaccines may stimulate or require all of this for the vaccine to be effective. Measurements of the immune system or the immune responsiveness to a vaccine or the strength of a response to a vaccine is quite challenging. So this is quite frustrating, I would say, to all of us, because if you have a condition, which we'll get to in a second, where your immune system may be imperfect or may be compromised, it's not easy or simple to measure that compromise, the degree of that compromise, and is the immune system a 9 out of 10 or a 3 out of 10? and what exactly do you need to fight off an infection? Is there a threshold? Are you in good shape if you're above a 5 out of 10? All of these kind of thresholds and cutoffs to say I'm in good shape or not so good shape are really, really hard to say. And the bottom line is that we don't have good data on all of this. So this is what makes this whole area very, very complicated, because patients would love to have something to say, yes, you're in good shape, don't worry so much, or no, you're not in good shape, be careful. And we're really not able to give somebody kind of a warranty or a strong assurance in a big way, in a very reliable way, in a simple numeric way or a positive or negative way to say, you're okay, don't worry, or you're not okay, be careful. And as you all know, even people that have quote-unquote normal immune systems, they can still get serious infections. So that's the other thing. It's much less if they've been vaccinated, but occasionally, as you've read and seen, that can still happen. So no one gets a pass, unfortunately, as much as we would love to have that. So this brings us to the concept of antibody tests, and I'm sure many of you have heard, some of you have had this idea of, I'm going to go get an antibody test to see how well the vaccine worked in me. And it's really important to remember that this is of quite limited value. If you've been vaccinated and you have an antibody test, you can't use this for very much to guide how you behave. And the guidance is such, for the most part, that these are not something that you should be routinely getting and making decisions based on the result of an antibody test. One reason is that defining a positive or negative antibody level is very subjective. And labs, if you've had this done, the lab may say you have a positive or a negative result, but we at Cornell and many other centers, and we published our data recently as well as many others in the literature, it's not a very simple black and white. Patients and individuals, particularly immunocompromised individuals, can be in a very middle ground. And so you might get a positive result or a negative result based on where the lab decides to call positive and negative, but you could be somewhere in the middle. And we don't know that that somewhere in the middle is necessarily a bad place or a safe place. So it's complicated to sort through all of that and to interpret those tests. These antibody tests do not measure the other parts of the immune response, the cellular part. They're measuring the antibody protein, but they're not measuring the cells. However, we do think that having more or some antibodies detectable by these tests probably is better than having none or fewer antibodies. So, it's probably better to have antibodies. I think we would generally agree with that. But how much better and how safe one is or isn't based on these tests is very, very difficult. And these tests are not validated for decision-making about anything you do in relation to COVID and vaccination. They're not really validated for patient care. There are antibody tests that you can look at to see if someone had an infection. There are different tests that can look to see if you had a past COVID infection, because you make different antibodies. You can make additional different antibodies to that. It's also really important to avoid false reassurance. We don't want people to say, hey, I have a positive antibody test, I'm protected, I'm in good shape, I can go live it up. Because as much as we'd like to say this, we all would like to say this, the fact of the matter is that we can't necessarily say that someone who has antibodies is in good shape, and we don't also know that someone who doesn't have antibodies is in bad shape. So we really can't or shouldn't be making big decisions on that basis. This is really something that's being done in research projects, but it's really not something that has been validated and applied in a way that we can confidently say that you can act one way or another or do one thing or another based on what your antibody test shows. So that's something that people really need to understand. I know that a lot of people are asking their doctors. I've had my patients ask for it, and we've occasionally checked it, but I've told everyone, really don't change your behavior on this basis. And again, we don't recommend the antibody testing to make decisions about what's going on with someone. So now let's talk about patients specifically with lymphoma and CLL, why these patients, these individuals, some of you have less protection from the vaccine. Well, I think you've probably figured this out by now, that having lymphoma and CLL itself, even if you're a patient who's been never treated, who's been on watch and wait, just the fact that you have lymphoma can be associated with a somewhat compromised, or what I like to say, imperfect immune system. So just having lymphoma there can be associated with an immune system that's not 100%. Now, those, I tell many of those patients that it's probably a 9 out of 10, but it could not be, or it might not be, a 10 out of 10. So again, these are just having lymphoma can be associated with an immune system that's not 100%. Lymphoma treatments, as many of you know, can impact and weaken the immune system. Patients who have gotten certain treatments, particularly multiple treatments and recent treatments, might be more prone to infections. They may have a diminished immune system, either with respect to the antibodies or the cells involved in the immune response. The factors that affect this may include the type of lymphoma that one has, the type of treatment. Different treatments have more effect on the immune system. The time from treatment, if you're getting treatment today versus if you had it just a few months ago versus if you had it 5 years ago, those all may impact the residual effect on your immune system. And it's really important to understand that data on categories of different patients and their status and their correlation with outcome are quite limited. So, we have some information out there that certain patients, based on different categories, may be more or less likely to make antibodies. But I just told you that the antibody test is not something that we make decisions on or are very robust with. That's been generated as a research tool. So it's the data saying that people that fall into these different categories may, being able to correlate that with a risk of infection or an element of protection can be quite challenging. And we're making assumptions based on relatively little data in some cases and extrapolation from other settings. So we cannot reliably say that this group is absolutely safe or protected. And generally speaking, we also can't say that this group has no protection from a vaccine. But we do know that certain groups of patients might be at higher risk. And those groups that seem to be at higher risk, now that doesn't mean that if you fell in one of these groups that you're in a horrible position, or if you're not in one of these groups that you're home free and great. But these groups tend to be associated with what we would expect to be less immune protection from a vaccine. So those include those who started lymphoma therapy before getting the first series of vaccinations. So I have a number of patients, as the vaccine was coming out, that we were able to hold off on their treatment, get them vaccinated, wait a few weeks, and then start their treatment. And that's a scenario that many people were able to do. But obviously many people weren't able to do that. Many people had already been on treatment or needed treatment or couldn't wait or have been on treatment for a long period of time, and then the vaccines came out. And those are people that, depending on all these different variables, if they've had lymphoma for a while and had lymphoma treatments, that then getting vaccinated after having lymphoma treatment, depending on the details, those may be people that are at a risk of a lower immune response. The time from that therapy is probably an important factor. In fact, it is an important factor. So someone who has been off of therapy, if they just stopped therapy a month ago or a few months ago versus stopped it 2 years ago or 5 years ago, the longer the time since the therapy, the more likely the immune system has recovered, and therefore the more likely that there might be some protection from the vaccine. Again, a lot of gray areas, a lot of a spectrum here. Anti-CD20 therapy. Many patients with B-cell lymphomas and CLL have received an antibody treatment, either rituximab or obinutuzumab. These have other names. But these are very commonly given to people with a B-cell lymphoma of various types. They're very good treatments for those B-cell lymphomas. But as a byproduct of that treatment, they can deplete the normal B cells in the body, and those normal B cells are in part, a big part, I would say, of allowing the antibodies to be made. So if you deplete your B cells, you're less likely in some cases, in some situations, to make an antibody in response to an infection or more commonly a vaccine. And so if you've had those therapies recently, your response to a vaccine may be diminished. The longer period of time, and there's no absolute cutoff, there are some gray areas in there. We would probably say between 6 months and 2 years is a gray area, and then longer than 2 years, it seems like the immune system typically recovers better. But again, it could recover or start to recover as short as 6 months after these treatments. Those are all factors that might say, does that therapy interfere or not with the vaccine response? And then there are categories of drugs that are used more commonly in CLL, but certain other lymphomas, what we call Bruton's tyrosine kinase inhibitors, ibrutinib, acalabrutinib, zanubrutinib, and a drug called venetoclax. These have, in small studies, been associated with a little bit less of an immune response in some patients, not all patients, but in some patients. And again, the test to measure the immune response is a surrogate, but it's not a good surrogate to knowing how well the immune response actually is protective. In part, patients with CLL. CLL has been associated with immune system issues and a lower immune system, perhaps a little bit more of an issue in CLL patients versus certain other lymphomas. And again, those therapies, the BTK inhibitors, are commonly used in CLL. So CLL is a scenario where people may need to be a bit more careful. And then on the other end of the spectrum, patients who have had very strong therapy for their lymphoma, patients in particular who've had stem cell transplants or CAR T-cell therapy, these are patients that may be more likely to have a diminished immune response and where the vaccine may not have worked quite as well. So a lot of potential categories, a lot of places to be maybe a little more concerned, a little more cautious, but not black and white things where you can say, hey, I'm in great shape or hey, I'm in horrible shape, just that we know that you may be in a group that has a higher or lower risk perhaps. So what do we know about lymphoma and CLL patients with respect to COVID-19 infection and vaccination? Well, we know that patients with lymphoma and CLL and many other situations can have, not always, but can have more severe disease if they get COVID. The breakthrough infections, meaning people that get infections that are clinically apparent, getting sick despite vaccination, that can occur in anyone. With a normal immune system, you can still have an infection and get sick from COVID, but the risk is lower. Breakthrough infections despite vaccination seem to be more of an issue in patients that are immunocompromised. So that is an issue, okay? So the importance, and then there are some categories of lymphoma and CLL patients that are less likely to have measurable antibodies. So we do have studies that show that certain categories of patients are less likely to have those antibodies. Again, what that means, it's probably not a good thing to not have antibodies, but again, the importance of using that antibody test to take action at this point is not something that is recommended. And so in this group of patients, it makes sense to take extra precautions because patients may be at greater risk, and to consider having booster vaccinations. This concept of booster vaccinations by now should be obvious to you. Can we give you more vaccine? Will that make an imperfect immune system? Will it raise up the game a little bit of the immune system, give it a little extra help, and get you over the hump so that you get better protection or a greater degree of protection or longer protection? And all of that makes a lot of sense in the abstract. So I would say to you that all lymphoma and CLL patients should discuss with their care team if they should have a COVID-19 vaccine, and the answer almost always is yes. But there are still some patients out there for a variety of reasons. Occasionally someone comes to my clinic and they haven't had a vaccine yet. You should talk to your doctor if you haven't. And I'm guessing most people on the call are interested in this area and paying attention to this and probably have. But I will tell you, I do have some patients that I've said, you're in the middle of treatment, maybe we shouldn't do it right now, maybe we should wait a little bit. So these are conversations to have with your doctor. But the vast majority of patients with lymphoma or CLL should be already vaccinated, and if they're not, really should talk to their doctor and likely get it. And I would say that virtually all lymphoma and CLL patients should talk to their care team to see if they should get a booster shot, or a third dose, it's sometimes called, either now or in the future. And so we're going to spend the last minute or two of my discussion on boosters, because that's obviously an important topic of interest to everyone. And this is rapidly changing. And so if I were to give this talk again in a couple months, maybe it'll be a different, but we're going to give you where we are today, knowing that this can change. So the rationale for boosters are that, or a third dose, is that, again, we're trying to improve the immune response. If it was limited or if it was insufficient, whether or not we could measure that. We want to potentially extend the duration of the immune response. We don't know for sure when the immune response will wear off, or if it wears off, or to what degree it wears off, or how important it winds down. So we want to make it longer. That makes sense. The early data suggests that boosters are safe. These third vaccines seem to be safe. And the early data suggests that for certain immunocompromised patients, particularly patients who've had organ transplants, so patients who've had kidney transplants, heart transplants, where this is also an issue. There are some good but small studies suggesting that boosters can improve the metrics, what we can measure in those patients. And so it makes sense that some people, not all, but some people with compromised immune systems may benefit from a booster. And it also, if you're following the news, you know that it seems likely that the general public will receive boosters soon. And we've seen in the news recently that within the next month or two, the government will be facilitating and rolling that out, with the idea that people without in a compromised immune system will also be getting some boosters. And again, this is a moving target. This will be a debatable issue, no doubt, for some people who have normal immune systems. But in my mind, this is a less debatable issue in people who are immunocompromised, because that's a place where some of us who are immunocompromised probably need all the help we could get, or at least look at it that way. So these are the latest guidelines from the CDC for immunocompromised people. And this has been in the news. You've probably seen some of this. I've distilled this down to some degree. The concepts here are that people who are moderately to severely immunocompromised, so that's a definition or a description of a group of people we'll come back to in a second, for the reasons we've talked about, are vulnerable to COVID-19 because they're at risk for a more serious or longer illness. They may potentially benefit from additional doses of the vaccine. We've touched on that. And so the CDC recommends that people who are moderately to severely immunocompromised should receive an additional dose of mRNA COVID-19 vaccine after the additional 2 doses. Okay, so that's a recommendation from the CDC, and some of you may already be either considering this or have even already had this. So who are people that are quote-unquote moderately to severely immunocompromised? Now, this group of people, and this is a definition or a categorization of people that is really I don't want to say arbitrary, but it's a grouping, and saying, well, who fits this category? And I look at this, and I think most of us look at this as this list, which we're going to go through briefly, is not the only group. It includes this group, but there are others outside of this group who are immunocompromised, whether one would call it moderately or severely, that one should consider doing a booster vaccine. But the group who clearly fit this scenario, according to the CDC, there may be others, and I believe there are others, include those in active cancer treatment for tumors or cancers of the blood, like lymphoma or CLL. So been receiving is a very gray area. It could be getting it now. It could have had it at some point in the past and received it. Received an organ transplant, taking immunosuppressive medicines. Received a stem cell transplant within the last 2 years, taking medicine to suppress the immune system, several what we call primary immunodeficiencies, disorders of the immune system, which we won't talk about today, patients with certain categories of HIV infection, and patients who are needing corticosteroids, so drugs like prednisone, that may suppress the immune system for various diseases. These are people that seem to fit in this moderately to severely immunocompromised group where the booster should be considered, but it is not limited to this group. It's very clear on that. So the CDC recommends that there's an additional dose of an mRNA COVID-19 vaccine given to these patients, that it is administered at least 4 weeks after the second dose of either the Pfizer or the Moderna vaccine. So at least 4 weeks. So most people who've been vaccinated are longer than 4 weeks since their vaccine. I'm guessing those of you on the call probably had your vaccine if you've been vaccinated. Most of you probably in the spring. It was really going more to the general public in January, February, March, somewhere in that time frame, some a little bit later. Some of you may have been recently vaccinated, but probably most of you, like me, were vaccinated more than 4 weeks ago. And so the question, and I've had calls about this today from patients, well, should I wait a little while longer? What's the optimal time? Should I wait 8 months, 6 months, 4 months, 12 months? We don't know the answer. But so that's something to think about depending on your situation and talk to your care team. But according to the CDC, it needs to be at least 4 weeks. So if you just had your second vaccine a couple weeks ago, don't go tomorrow and get your third. It's too soon. Beyond that, we don't know the answer to. For people who received either the Pfizer or the Moderna vaccine, a third dose of the same mRNA vaccine should be used. So you should try to get the same one that you had before. And I've had people ask me, well, if I had the Pfizer, maybe if I get the booster and the Moderna, I'll have a better response. It'll work differently. It'll make my immune system different. That's not the recommendation from the CDC. The CDC recommendation is to get the same one you had before. If you can't get it, if it's not available to you, and not available is a relative term, obviously, because you may have to travel or wait or whatever it is. But the idea is if you can't for some reason get the same one as the third dose, you can get the other one if that's what's available to you. But in general, what the CDC is recommending is that you get the same one. You should not receive more than 3 doses. So that question, well, if I'm immunocompromised, why if three's better than 2, is 4 better than 3, is 8 better than so on? No. At this point, the stop at 3. And, who knows, maybe in a year or whenever we'll have more data and we'll be getting these every year. But at this point, 3 is what you should be getting, okay? Now, the questions about the Johnson & Johnson vaccine, I would say it seems like relatively fewer of our patients have received the Johnson & Johnson one-shot vaccine, but it seems likely that those patients will benefit at some point from some type of booster. But the Johnson & Johnson vaccine was approved a bit later, if you recall, a couple months later, I believe. And so we don't have as much follow-up as to how those patients' immune responses are doing, et cetera. So I suspect that we will have data on that and there will be some guidance. But as of today, the guidance is that if you have the J&J vaccine, you just sit tight, but pay attention to the news because this may change, and talk to your doctor. It seems likely that those patients will also get a booster and have a booster recommended. So a few additional comments. So the chronic medical conditions. So I told you that the CDC has these moderate to severe immunocompromised, but a variety of other medical conditions, including lymphoma and CLL, may be associated with varying degrees of immune deficit. We've talked about that. So your team is really the team that's best able to assess the degree of where your immune status is based on your history, what type of lymphoma, what type of treatment, what's planned in the future, what you've had before. So you really need to talk to your team. So, the idea that I could give you everybody in this category should get it, everybody in this category should wait, particularly when for many people it's not a matter of if, it's when, because if you're in the middle of treatment, you might decide to wait a little while. Those are all things you need to talk about with your doctor. As I said, whenever possible, the vaccination should occur at least 2 weeks before starting immunosuppressive therapy. So if you've been on watch and wait, or you haven't had treatment for a long time, but your disease is getting to a point where you may need to do something, the recommendation is to try, if you can, and it doesn't mean make yourself sick if you can't, but try to get your booster or your initial vaccination, and try to do that a couple of weeks, 2 weeks before you start your therapy. So if you've been talking to your doctor about starting a treatment and things have been slowly getting worse with your lymphoma or your CLL, you may want to take the tack of let's get a booster, wait a couple weeks, and then start the treatment. So that's a conversation if you're in that scenario to think about it. And then the last bullet point here, really important, the utility of antibody testing to assess immune response and guide the need for an additional dose has not been established and is not recommended at this time. So you should not make this decision based on an antibody test. So I have had people say, well, I got an antibody test and I was negative, so I'm going to go get a booster. That is not the recommendation of the CDC. The recommendation is that you make this decision based on your clinical scenario and everything, and most people should be getting the booster, with some of the exceptions that we talked about, regardless of whether or not they made an antibody. And it may be, I'll give you a flip side scenario, which is totally hypothetical, so don't take this away. It may be that people that made antibodies are the ones who are going to respond even better to the booster because they made antibodies the first time. It may also be that those that didn't make antibodies are the ones that are going to respond to a booster. It may be that the antibodies that we measure are not at all a guide to anything and don't mean a whole lot, and therefore the whole idea is to just do what we can automatically to boost your immune system, but we should not be using antibody tests to make this decision. So don't go request an antibody test to decide this, and talk to your doctor, your care team, decide to do it or not do it, but don't use an antibody test beforehand, and don't do an antibody test to see if it worked, because that's really a research project we and others are looking into, but it's not something that we're using, that anybody should be using to guide their care. And I'm going to wrap up because we're going to get to the Q&A in a minute. The other really important thing, we don't want false reassurance. Immunocompromised people need to continue to protect themselves by wearing a mask in different situations, particularly when they're around unvaccinated people or potentially around unvaccinated people. Social distance, 6 feet apart from people you don't live with, avoid crowds, avoid poorly ventilated indoor spaces, especially if you're not wearing a mask. And encourage your friends, your family, the people you work with to get vaccinated, because again, if you have a cocoon around you of a family that's all been vaccinated, if you're able to do that, that's going to be good for you to the extent you can. Obviously, people with young children who can't get vaccinated, that's an ongoing point of discussion. And but really, that is a really, really important part of all of this, is just encouraging everybody to take care of themselves and take care of everybody else. And then I'm going to finish here, but we're going to come back to the Q&A. Some of these questions I think I've touched on. I'm not going to read through them all because we're going to come back to, but there are a number of different questions that come up, and we're happy to discuss these a little bit more. It's not going to hurt your lymphoma by any stretch that we have, and some of these areas I've already touched on, but activating your lymphoma is not a concern for the vaccines. There's no evidence of that. And I think at this point we'll stop and maybe come back to some of these issues over the next few minutes. I'll turn it back to you, Victor.
Thank you so much, Dr. Leonard, for such an informative presentation. We know that many of you on the call today have questions about your own situations, and just as Dr. Leonard described, while others might not be fully sure what questions they should be asking. So to this end, and for this reason, LRF has developed a new patient resource called Questions to Ask Your Doctor About a Third COVID-19 Vaccine. This resource will hopefully help you in your conversations with your healthcare team to determine what are the next best steps for you. You can access this resource on our COVID-19 Learning Center at lymphoma.org, or by contacting our helpline. We're happy to send you a link. Now we will begin our Q&A portion of the program. For this webinar, we will be reading questions that were submitted in advance. Some may involve questions you touched upon, Dr. Leonard, but it may be helpful to cover them again for anyone who missed it earlier in the call. And if anyone on the call does have a question that does not get answered, you can always reach out to the LRF helpline at 1-800-500-9976 or email helpline@lymphoma.org, and we will try to get that answer to you as soon as possible. And now for our first question, and it is, are patients who were treated with an auto stem cell transplant for mantle cell lymphoma more than 5 years ago considered immunocompromised, or is this only true for patients currently in treatment?
So this is an excellent question, and one that is difficult to answer. It highlights a few different points. One is that stem cell transplants are very immunosuppressive. Those of you who have considered them or had one know that you need to worry about infections for a period of time during and after the stem cell transplant. But it also highlights the fact that as time goes by, that the immune system recovers. The question is the immune system perfect, even 5 years later or even longer? And so what I would, and so how this relates to somebody who is worried about their COVID risk or worried about should they get vaccinated, well, the answer is they should, generally speaking, get vaccinated. And that's probably someone I would tell to get a booster shot as well for the reasons we've talked about. How immunocompromised that person is on a relative scale is hard to say. So I would say that person is at a bit more risk than someone who hadn't had lymphoma, hadn't had chemotherapy, hadn't had a stem cell transplant. Many people for mantle cell lymphoma also get rituximab after their stem cell transplant for a period of time. So generally speaking, I would say that person has some degree, and people in that situation have some degree of a compromised immune system. Where it is on the scale and what exactly they should do, important to speak with the doctor or care team that's providing for them.
Thank you. And the next question is, I had the Moderna vaccine in February and learned in July that I had that the CAR T I had a year and a half ago may have blunted my vaccine antibodies. In desperation, I got the J&J vaccine. Do you think this will help, and can I still get a third Moderna shot?
So that's a great question and a complicated question, and one that I don't have any answer to based on any data, because I can't cite any studies of people in this particular scenario who've had CAR T cells who got one vaccine and then got another vaccine, and then what did they have? So that's the challenge of all these, is that there are thousands or hundreds of individual scenarios that all have their nuances. And if you try to say, well, how did people in this situation who were treated on a study do, and what worked and what didn't work, we don't have data. So I'm going to come back to talk to your doctor, talk to your care team. We do know that patients who have had CAR T cells, which is a form of immune therapy for lymphoma that involves removing the T cells and engineering them to fight lymphoma, giving some immunosuppressive treatment, and then giving back these T cells to fight lymphoma. This can be a useful and effective treatment for certain lymphoma situations, but it does suppress the normal B cells. Those T cells can, by way of how they're engineered to fight the lymphoma, can, as a byproduct, affect the normal B cells. So someone who's had CAR T cells, and that was on our slides, can be at a greater immunocompromised risk, can also be less likely potentially to respond to a vaccine, one would envision. So the idea of what to do there, I think if you're in this situation right now, would be to get, if you've had your 2 vaccines, to get a booster. Talk to your doctor as to what the optimal timing of that is. But someone who it sounds like is this far out, sounds like it's a reasonable timing, but talk to your doctor about that. And as of now, we don't mix and match. So for someone who has had 2 and then 1, has already had 3 vaccines, I can't recommend to go get a 4th, but I would, pay attention to what comes out, talk to your doctor about where things are going, because we don't have much data to say exactly what to do. And at this point, 3 is the limit that we can be recommending, and continue to use precautions as well and be mindful of those sorts of things.
Great. So the next question is, my loved one has follicular lymphoma. The CDC site says the booster authorized for the immunocompromised is not the same booster the rest will get. Is this correct? And if so, why?
So to my knowledge, the booster shots are essentially the same as the initial shots. So I'm not aware of any differences about in that. So the third one is basically the same as the first and second, whichever one you're doing. So that, I think that answers the direct question. So we generally, for somebody with follicular lymphoma, depending on the details of that person's history, but in most cases, we would say get vaccinated and also get a booster. And if you're, again, have had treatment or in the middle of treatment, certainly talk to your doctor about the timing of when to do that.
Thank you. I'm undergoing treatment for CLL, and I just got my 3rd Moderna vaccination. My understanding is that this was an attempt to stimulate further response following the first 2 shots. Will I and others in similar situations be able to get a booster as well? So I'm assuming that means when the rest of the population can get it.
Well, I think that, and there's this discussion about, is a 3rd shot a booster, or is a 3rd shot kind of a completion of the first 2 for people where the first 2 might not have worked as well, which we don't know for sure. I would say that at this point, someone who's presumably had their first 2 Moderna shots and then got a 3rd or a booster shot more recently, it sounds like, that people in that situation should not get another shot for the time being, but I would expect that, in certain time frame, in 6 months to a year, we will have more guidance about that and more information to guide that decision one way or another. Again, it may not be perfect information, but it'll at least give some information as to what to do. But for right now, I wouldn't, and as I cited in the CDC guidance, we don't give a 4th shot, or we don't recommend to give a 4th shot at this point. But, this is all changing, as we all know. I mean, we weren't really talking about booster shots 6 months ago, and now we've spent the last few weeks and just now almost an hour talking about the role of boosters. So it's quite possible that in 6 months or a year or whatever the time frame is, that there will be more shots, and hopefully, certainly I would expect more information to help people navigate all of this. But for right now, we stop at 3.
So next question. What do we know in terms of data about the increase of antibodies for immunocompromised populations with a 3rd dose of Pfizer?
So the data that we have for patients with 3rd doses are largely in patients that for immunocompromised patients, are largely in patients who have had organ transplants, as I mentioned earlier. These data are quite limited. I think it's safe to say that some patients that are immunocompromised will have a measurable antibody response to a 3rd dose, even if they didn't respond to the 1st or 2nd. I think that's likely. How many of those people, we don't know. And most importantly, I'm not sure that we need to focus on what the antibody response is. I think, again, that's a research tool that's being studied to try to sort through. I would look at it as it is likely that someone who is immunocompromised, who had 2 COVID vaccines, that person will have some benefit, and it may be a large benefit, it may be a teeny tiny benefit, it might be 0 benefit, but I think there's a reasonably good chance that there will be some effect of that 3rd vaccine, and that for some people that 3rd vaccine effect will make an important difference. But there's no good way to measure it or to make decisions based on it. And I certainly, as I alluded to, wouldn't be saying, well, I got my 3rd shot, so now I can not take any precautions and forget about all of this. I think you should get a 3rd shot with your care team's advice. because it could help you. And, we all want to be helped and we all want to avoid serious infections. But again, I wouldn't focus on measuring antibodies as the output of that. I would say, the hope is that there will be benefits of the vaccination to the immune system and that will make a difference for some patients, hopefully a large number of them.
Thank you. The next question is, I was recently diagnosed with MCL and will begin chemo in early September. I received the 2 Moderna vaccine shots 6 months ago. Should patients with similar challenges get booster shots before starting chemo?
So I would say that generally speaking, if someone has had 2 vaccinations, has not had any chemotherapy, but is likely to get some therapy in the near future, like this patient describes, and there are many others out there, that if that's anticipated, sometimes we can say, hey, that's likely to come in the next month or 2. Sometimes we can't. Sometimes it happens immediately. And if you're sick and need to start immediately, you should start immediately, obviously with discussion and management of your doctor. But for someone who's planning, a few weeks or a month from now, based on their situation, anticipating that they're going to need to start treatment, we would generally say that getting a booster shot, particularly if some time has passed, at least a month, and in this case 6 months since the initial series, that it would seem to me to make sense and to fit the guidelines that if possible, getting a booster at least a couple weeks before starting therapy is probably a good idea based on what we would expect. So yes, that makes sense.
Thank you. Next question. I was diagnosed with follicular lymphoma. Since then, I've been in observation as no treatment is needed so far. I received 2 doses of the Pfizer vaccine. Do I also need a 3rd dose?
So someone who has follicular lymphoma or indolent lymphoma who's been on watch and wait has not had their immune system affected by chemotherapy or rituximab because they haven't had it. They probably have some element of an imperfect, as I would say, immune system, but it's not been heavily affected by treatment because there's been no treatment that could do that. So the question then is, should such a patient get a booster if they're, and I'll invent a term here, if they're mildly immunocompromised, meaning that they don't fit into the categories of having had a lot of treatment or any treatment in the past that would affect their immune system. So that is really a discussion with your doctor to say, hey, if your immune system is imperfect, does it make sense for you to get a booster? Or does it not? Because, your immune system might be a 9 out of 10 and maybe you don't need a booster. I would argue that personally that most patients, and again, you need to speak with your doctor and talk through your concerns and your preferences and your doctor's concerns, but I would argue that most patients in this type of category should probably get a booster because they don't have perfect immune systems, and it seems like the general public is going to be getting boosters anyway soon. And assuming that all comes to fruition, that if people with normal immune systems, and again I use these terms loosely, but if people with normal immune systems should consider getting a booster, which seems like that's going to be happening soon, then somebody with an immune system that is not quite normal, perhaps a bit imperfect, should also think about doing that. So that's a scenario where I wouldn't be compelled to get a booster, but I probably would advise most of those patients to consider it strongly and to get one. But again, that's something that you need to discuss with your doctor.
Thank you. Would CLL patients who fail to demonstrate a spike protein antibody response after vaccination also fail to develop T-cell memory response to the COVID antigen?
So the patients with CLL can either associated with CLL itself or with some of the treatments might have an impaired B-cell response and therefore not make antibodies. They also, like some others, might have an impaired cellular immune response, in particular a T-cell response that might be diminished because of their CLL or because of their prior therapy. So I would not recommend, gauging things as far as an antibody response or an immune response by measuring antibody levels. But antibody levels do not measure a T cell response. And to be honest, we really don't have there are some research tools, but we don't have a commercial laboratory test that you can send that in any robust way says, well, you made or didn't make an immune response to this vaccine, and therefore you have some degree of cellular or T cell immune response to this vaccine, so you should be more or less concerned. So I would say, though, that somebody with CLL who's presumably had treatment, those treatments could have they could affect B cells, they could affect T cells, and therefore that falls into a group that could be immunocompromised by the nature of having CLL and having CLL treatments.
Thank you. And this will be the last question of the day. And the question is, should I get a booster shot too if I have a cutaneous lymphoma that's limited to the skin?
So there are cutaneous lymphomas that of various types, both T cell and B cell lymphomas that can involve the skin. And again, I would say that these are, some might argue, well, it's only involving the skin. That's not. Some might argue that's not an extensive systemic. It's not affecting my system in a big way. Therefore, my immune system should be in good shape. But I think it's hard to generalize. It's hard to know for sure. And I would suggest that even patients with skin lymphomas or otherwise limited lymphomas, talk to your doctor to say, should I get a booster? And in many cases, should probably consider getting a booster.
Great. Well, thank you so much, Dr. Leonard, for your time today. And thank you again to each of you for joining us on today's call. We hope you found the information informative and also hopeful. Please remember, if you have any additional questions, you can reach out to the LRF helpline at 1-800-500-9976 or helpline@lymphoma.org. Also, at the conclusion of this program, you will receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this brief evaluation, as these are important for helping us deliver the most useful and meaningful programs to you. And with that, I would like to thank you all again for joining us. Please have a wonderful day.